Welcome, everyone. I'm Rajiv Kumar. I'm the chair of the membership committee, and Bob Reynolds and I welcome you to the PGN. We're so happy that you have joined us as PGN members. Bob asked me to lead this group, so we'll have quarterly meetings. This is our first call. I want to remind you that it is my duty to remind you that AMDA, the Society for Post-Acute and Long-Term Care Medicine, maintains an official policy with respect to the disclosure of bias and potential conflicts of interest and related party transactions. If you have a question about whether you should make such a disclosure and you're about to participate in a meeting where that conflict would apply, you should ask the chair of the meeting whether you should absent yourself or not participate in the discussion for its duration. So now let Lori take over for the next agenda item.
Thank you. I just have a few things to go over. We sent out an email yesterday, and I believe we sent another one out right after the annual conference. There are some new resources that are available to this group. So AMDA's 2018 archived practice management conference sessions are now available. There are 12 sessions in total, all of which are free with your Practice Group Network membership. To access them, log into your AMDA account. You will then be taken to the My Accounts page where you can click on Practice Group Network Benefits. You could also access it from clicking Practice Management from the top navigation. And then from there you can access your practice management webinars, your conference sessions, and your tools subscriptions. So for the conference session, for example, it included the pre-conference ticketed program, which was the meeting that took place on the Wednesday of the conference, along with 11 additional sessions. So I highly encourage everybody to take advantage of that, and please let the rest of your groups know that all of this information is available to them. In the email that we sent out yesterday, it includes a link to this information. Additionally, on May 9th, you were invited to attend the Advanced Care Planning and Long-Term Care webinar. If you were unable to attend that webinar, it is now archived and available for viewing. You can access that from the Practice Management Benefits page as well, along with all of the other practice management webinars that are posted. And once again, that is included with your Practice Group Network membership. And on a related note, in March at the annual conference, AMDA introduced our new Advanced Care Planning series. This is also available to all of your groups. To access the tools, you can access that from the benefits page and click on any of the tools, and they will open up an electronic version right in your browser where you can sift through all of the pages, and if you scroll down, you can display them full screen. And the last note I had was AMDA on the Go is the Society's new podcast, and it launched in February or March. We now have 7 episodes available and will continue to launch 2 per month. These podcasts are available for free to everyone. You can learn more by visiting paltc.org/podcast. We also have a link to it straight from the homepage. These podcasts are eligible for ABPLM Medical Director credits. Please feel free to share the podcast with all of your colleagues and friends. Like I said, this resource is available to everybody. They're hosted by Dr. Wayne Saltzman, who is extremely dynamic. He's throwing his heart into these. And they're pretty short. They're about 17 minutes long. So they're perfect for your daily commute or if you're eating lunch at your desk. You can access them through the website and play them directly from your computer, or you can access them via the Podbean app or via an RSS feed if you have an existing podcast app that you use. And if anybody has any questions or is having any trouble, please let us know. But they've received great feedback so far, so we would love to have more people attending those as well, and if you could help us spread the word about them. Any other questions for me?
Thank you, Lori.
All right, well then move on to Alex.
Hi, everyone. Alex Bardock, Director of Policy for AMDA. So we've been busy since March, since we met at the annual meeting. A lot has actually happened in the last several months. We anticipate a lot will happen through the summer as the various regulations make their way through CMS. This is typically a rulemaking season that lasts through the summer, and we're busy developing comments, sifting through different things, and figuring out where we stand. What's on the screen, if you're following there, or if not, I'll go through it, is sort of a bullet-pointed list of everything we've done. The goal here is not to go through any detail on any particular issue. However, this group is, we value your input. So if you have particular input on any of these topics, please stop me and let's, have a discussion and let's dig a little bit deeper. So the first bullet on the list is the GWEP funding legislation that's been introduced. This has been a long-standing issue that AMDA has followed. These GWEPs are the geriatric work enhancement programs, essentially dealing with geriatric training for direct care workforce, but also from our standpoint, from AMDA, some of that funding is used for our Futures program, our foundation's future program to train more clinicians in post-acute and long-term care. And as you may know, our current president, Carrie Levy, and others have gone through that program, so it's extremely valuable. So each year, these GWEPs that are around the country have to be reauthorized. Right now, there's sort of, there are threats to not authorize them, and so there's legislation that was introduced in the Senate that we sent you a link on that we're asking everyone at AMDA and beyond to support. And so we're asking you to do some grassroots letter writing. I don't know if any of you are familiar with the GWEPs or participating in any of these GWEPs. If you are, that's fantastic. And I'd urge you to actually edit that letter a little bit and talk about your personal experience and why that's important. And we can help you if you have questions. But please take a look at it and see if you could send a letter to the Hill, to Congress, to gather more support. So that's what GWEP funding is all about. I actually was just on the Hill this morning, talking about it, so it's a very important issue. The second, any questions on that one? Okay. The second issue listed here is this DEA nurse agent issue, and we could spend a lot of time going through the history of this and talking about how we got here, but in the interest of time, all I will say is this is about the prescription of narcotics, Schedule II narcotics, and the fact that you as a physician practice cannot use the nurse that's employed by the facility as your agent, and so you have to do a bunch of workarounds to prescribe Schedule II narcotics, and this has been an issue ever since the DEA went and fined a few pharmacies in the Ohio region in 2008/9. So as you can see, this has been a long-standing issue. We've worked with a wide coalition on this issue. At the center of it, Association of Consultant Pharmacy, but also includes American Healthcare Association, ACA, Leading Age, and others. That we've worked together to try and figure out a way to circumvent sort of this nurse agent, for short, as we call it. What we've found out in the last several years is that ASCAP has been working directly with the DEA on some proposed solutions. So what was included in your packet is an attachment of a proposed language that ASCAP has kind of developed and is asking for input from the various organizations before they send it to the DEA. This is a statement of policy that they believe can be used in order to mitigate the whole issue and try and resolve it. And there's also a sample agreement. Part of the issue, of course, is that the nursing facility and the nurses there are not agents of the DEA, so the DEA lacks enforcement mechanisms for controlling what's going on. So there's, from diversion to other things, there's been a lot of conversation on how to deal with this. We've even had some legislation introduced over the years, and that's gone back and forth. But what we're asking you today is to take a look at that policy statement and see if it makes sense from your perspective as a prescriber who's trying to work through this. And if you have examples, please let us know. Any questions on that front?
Yeah, Alex, hey, it's Rich Pfeiffer.
Yeah.
You mentioned something about a packet and some documents. Maybe I'm just a little bit clueless, but I don't see having received anything. Is that something available via the website? Something I should have received?
Lori?
For the DEA?
Yeah, so there's a bunch of attachments. I'm not sure if that was, if not, we'll send it around.
Yeah, I don't think I have the attachments. Otherwise, I'll look and I'll send them out after the call.
Okay, yeah, so, okay, my apologies. I thought you had them. So I will send that to you after the call. Please take a look at it and send us any comments on that. And again, this is something ASCAP has come up with and are asking for input. So we will provide input, ALCA will provide leading age, and so on. And so the goal is to eventually send this directly to the DEA and see if they want to resolve this issue. Anecdotally, ASCAP has heard that they want to, and so we're trying to come up with some solutions. Whether that happens or not is anybody's guess. All right, let's move on to the MACRA grant application. So I don't know if I'm the best person to speak about this or not, but as you know, we talked at the annual conference if you were there, and if not, you may have heard us talk a lot about the fact that the current state of quality measures in the MIPS program for you guys is not the best, and that's putting it mildly. And that there's a great need to develop quality measures that truly represent the quality of care that you guys provide, and that also aligns with the facility and also does not increase the burden of reporting, and in fact perhaps goes into the workflow of what you are currently doing, and that's the goal. Now that's easily said, much more difficult to do. So at the annual conference, we received word that finally this, what's called MACRA grant funding, or as part of the statute, there was an amount of money, $30 million, that is allocated to quality measure development by physician specialty societies. So they issued this grant application process, and they've asked physician specialty societies to quote unquote apply. And they called out several areas of gaps that they're going to focus on. Some orthopedics, for example, and hospice and palliative medicine, and not necessarily our space. So we had a challenge in that we had to figure out a way to write our proposal that proves to CMS that there is a gap in quality measures for clinicians practicing in the SNF, NIF environment, and come up with quality measures that are not currently being worked on and would be potentially considered a gap that CMS would be interested in and would move the needle in quality of care and improve patient outcomes. So there was a strict criteria which we sort of had to follow in order to even quote unquote have a shot, which is a long shot, I should take at the outset. So we did that. We went through a process with the RAND Corporation, Dr. Carrie Levy, Chris Laxton, I think you're on the phone, so weigh in on this. But we eventually came up with measures around UTIs and catheter-associated infections. And again, that went through a process of looking at the landscape of current measures, trying to figure out where the data could come from, could it be easily collected. And we understand that is not there's no perfect answer to all of this, but the goal was to try and figure out how to pick an issue that made sense and that fit within your workflows, and that's being focused on CMS with the antibiotic stewardship and some other things. So that's where we ended up. We submitted this application last Wednesday, and essentially we now wait to see if we'll get funding. Obviously, we view this as a first step in a bigger goal of defining quality in post-acute and long-term care. It does take money, and so we need either this funding or funding from other organizations to move this forward. And obviously, this exercise with RAND was, even if we don't get the funding, was very much worthwhile to do. So one of the attachments, that we'll send if it hadn't been, but what's on the screen if you are on the Zoom call right now is the project narrative that we put together. This was an 100-page application process, so there's a lot more to this. But just for your benefit, if you want to read through why and what and sort of the argument we made, read through the project narrative, and I think that'll give you a good sense of where we were trying to come from. But just wanted to give you an update on that, that we followed through with the promise of applying for this application. You know, we had a choice. We could either sit back and say this was not something CMS is going to fund, or try and figure this out. And that's where we ended up. Chris, anyone else that was a part of this that wants to comment any further?
Yeah, thanks, Alex. It's Chris. It was a massive effort, but as Alex said, I think it's worthwhile from a number of points of view. For one thing, it really demonstrated one of the reasons it's so difficult to measure physician-sensitive quality indicators in our space, and that is that the data that are going to flow into this measure come from a lot of different places, and that is it's a major obstacle to essentially improving the quality of care for these residents. I think, again, regardless of the outcome of this funding, I think one thing that's very clear to us at AMDA is the degree to which a better integration of these data systems is needed, and we're definitely going to push for that regardless of the outcome. And then secondly, if we do get an award, one of the things we're going to be doing is trying to build a data collection facility that will allow physicians to report on the various measures around urinary tract infections. So that again is a bit of a game changer, I think, because it would give our clinicians a resource that they don't have at the moment, and should flow into a registry that will be reportable to CMS for payment. So yeah, we're keeping our fingers crossed and hoping this comes through, but important that you know that this activity is going on.
Okay, any questions on this particular topic? I'm sure you may have a lot of comments, but yeah, anything anyone wants to add? Okay. All right. Well, if you read through this and you have questions and you have thoughts and opportunities for the future of how we can develop quality measures and improve your experience with the current programs, please let us know. Lori, do you mind going back to the agenda? Because I don't have all of the things memorized.
Sure. Let me just pull it up.
I can't open it. Okay. Yeah, I got it. Thank you. So this next item is DPC for short, or direct provider contracting. This was a request for information that came out of CMS, and essentially what they were asking is how to structure models of care that CMS would directly contract with clinicians, and how would those models look like? There were a number of questions that were included in this request for information. We had about slightly less than 60 days to respond to this, and so we worked actually with the Practice Management Network and our APM work group, which Dr. Rajiv is on, to figure out, how could it be structured. And what if we haven't gotten it, the attachment that we have is our response. And a couple of things we talked about. One is the importance of the fact that clinicians in this space, and particularly in post-acute and long-term care, have to be able to themselves take some downside and upside risk. So they need to be able to participate and incentivize themselves to participate in these programs and be engaged with their facilities, because then we know through the current BPCI Model 3 experience and other models that engaged clinicians, trained engaged clinicians, are what's going to improve quality and reduce cost, rehospitalizations, length of stay, and all kinds of things. we also took some time to discuss the difference between a skilled nursing facility and a nursing facility. We really wanted CMS to understand that there are these differences in this setting, and so we went to through a bit of an explanation that we have written in many other letters, but we felt like that was something of importance to include here as well. So you could read the comments. I won't go through all of them, but that was really, I think, the gist. And importantly, we also spoke with AHCA, American Healthcare Association, which you're all probably familiar with, and discussed this idea with them, this idea that we need to come together, facilities and clinicians, to figure out a way that both clinicians can participate in these programs and take upside and downside risk, and facilities can do the same and achieve the same goals. AHCA did send a letter themselves, and they included majority of what we discussed with them. They included in their letter, which I think is a very positive step forward in the fact that this quote unquote, as I call it, sector of healthcare, post-acute and long-term care, can speak with one voice. And so that's a very positive thing. They didn't have to respond to this RFI, given that it was dealing with contracting with clinicians, but they elected to because they wanted to support the concept we proposed, and also made some comments, of course, as it relates to lack of available models in the SNF and NIF space. So that's where we are with that. Dr. Kumar, do you want to add anything? I know you were a big part of this discussion. So anything you want to add?
Sure. It was wonderful to work with them. They started, when I say they, it's AHCA, HCA. They were thinking that physicians would be averse to taking risk. And we convinced them that no, we would enjoy taking risk. If we do a good job, why not get paid for it? And if you don't want to take risk, you don't have to participate. This is optional. And so they were thinking initially that maybe the SNFs would take the risk and physicians would be part of that risk-taking endeavor. But we said physician practice is perfectly capable of taking some risk and reaping benefits, but would also be open to working with them, especially in a Model 3 type of a bundle if it comes back into force. So it was a good collaboration.
Great. Any questions, concerns? If you haven't read our comments, again, we'll send them out, so that might give you a better sense of what we talked about. But welcome again your input on any of this. But any questions? Okay. All right. So the next two items are somewhat related, but different. The specialty status application. We want to continue to update this group of where we stand on this. As it is sort of it is a very important item, particularly as it relates to all of the value-based medicine initiatives, and that is the AMDA's application for a specialty status designation for those clinicians practicing, or physicians really practicing, in the skilled nursing facility and nursing facility space. For those that are not familiar with where this came from, this is very similar to what the hospitalists were able to do successfully. And if you're familiar with that world, they are now implementing a code that is a physician-elected code, is a voluntary physician self-elected code through this PACOS system that they select, and they select themselves as a hospitalist. And what it allows them to do is essentially, when the MIPS scores are compared, now CMS can more easily compare a hospitalist to a hospitalist, whereas in the past they had to compare a hospitalist versus a family or internal medicine physician. Clearly the same is true in the SNF and NIF world, where the biggest problem is that your overall MIPS score is compared to those of internal medicine and family medicine and ambulatory practices. And we know that the current risk adjustment models and other things are just not adequate enough to figure out a way to make this an equal scale. So we followed very closely the hospitalist model when they were going through this application process. And so what essentially it involves is us sending this letter, which is an application to CMS for them to do this. We did this in August of last year officially, although we had begun conversations with them even before that. But officially, we submitted our application last August, and we have been in constant communication with the office that's responsible for this policy. What we hear right now is that they have our letter, they have our application, and it's under consideration. Unfortunately, there isn't a blueprint or a model or a timeline that they have to follow in order to make these decisions. So once you submit this application, you sort of just wait and see. And so we keep kind of contacting other folks at CMS. We talk to that office, and the response we've gotten so far is, we have your application, we hear you, we have everything we need, we don't need to meet with you guys, we'll let you know. And that's, from what we hear, that's a very similar experience to what the hospitalists went through. It took them about 7 years in 2 different efforts to get this done. So if this happens quickly, that's fantastic, but it may not. So just wanted everybody to know that. But we are pushing for it. If anybody is interested in sending a letter to the Office of Program Integrity or Practitioner Services, sorry, please let us know. Your own letters can help support the AMDA application, and if you want to do that, we can help you do that with your own data or however you want to do that. We're happy to take your letters and send them in as well. So that's where we stand right now. Any questions on that front?
Hey, Alex, it's Rich again.
Right.
At the risk of being a broken record,
I know.
Just wanted to say that you and everyone involved is very sensitive to the primary care designation that would be necessary if we get categorized on our own. It's possible, but if that is for whatever reason omitted inadvertently, it would be nothing less than disastrous for Genesis, and so we wouldn't support it. So I really want to make sure that's on everybody's radar. Yeah,
Rich, and we hear you. I understand, and so if and they actually take this up, obviously we want this to be a primary care designation, and you know we've been in contact with the hospitals to figure out how their models are working out, and so unfortunately their code, as you know, is just now going in. So we don't have a good sense of, you know, how did the data get shifted around once people started using the code. So, but your point is well taken, and we welcome Genesis, of course, sending their own letter of support and making the point you just made with a specific example to make sure that this is done right.
If you can maybe offline help me understand to whom a letter like that should be sent, I'd be glad to work on it.
Sure.
Thanks.
Any other thoughts, questions? Okay, so the next item is sort of related to this, but of course different, in that since we've begun all of this discussion about the specialty status application, there's been sort of another opportunity that's out there now. Part of the issue, of course, with our specialty status application is that we don't have a separate ABMS-defined certification for SNF physicians. So one of the barriers had been, prior to the hospitalists getting their status, had been that in order to apply for a code, you had to be recognized by ABMS in some way, shape, or form. Of course, we're not. So, however, it looks like last year, ABMS created what is called a specialty focus designation. If you were at our annual conference, Dr. Bob Kaplan, who's the chair of ABPLM, talked a little bit about that. But I wanted to send you some information on that, and again, we'll send the attachments. There's an FAQ that talks about it, but essentially, even in the first FAQ, it calls out that if you practice in a hospital and you're a primary care physician practicing primarily in a hospital, you can get what's called a specialty focus designation, and that's through ABMS. So that carries a lot of weight, obviously. So we don't have any answers on this. We have no idea how this would work for our setting. But what we wanted to put this on your radar is the fact that ABPLM is looking at this. They have not made any decisions. We have not submitted any applications. We don't have anything to report on that front. In fact, I think their meeting is coming up where they may discuss this. So I don't want to jump ahead of where they will land on this or anything like that. But we did want to kind of let you know that this is something that we are exploring in case you may have heard about this. And we will keep you updated as sort of the process moves forward. If that's something that ABPLM and AMDA decides is worthwhile pursuing, we may seek your input and figure out, where we go from here. But certainly this could have an impact on everything we've talked about in terms of the post-acute long-term care, or SNF-NIF, being a specialty and perhaps receiving the same specialty designation. The hospitalists have been the first to receive this sort of thing, so we'll see how it plays out. Any questions on that, on this one? Okay, that's all I had for updates. I'll get back to anything that might happen in the future. But as you can see, this all happened since March, so it's been a busy couple months.
Yeah, I concur with you, Alex. We've had a busy season. This is Rajiv again. I'm going to briefly give you an update on the PDPM, the patient-driven payment model that's proposed by CMS to reimburse SNFs. As you know, we've had RUG 4, that's the model that exists today, which is heavily therapy-driven in terms of how SNFs are reimbursed for care they provide. So CMS proposed RCS1 last year. So we did talk about it. I think there might have been a session at the annual conference as well. That's a resident classification system. So the change was going to be, instead of using therapy as the prime driver of reimbursement, CMS was proposing use resident classification, in other words, patient characteristics. So it was a ICD-10 driven model. And there were a lot of comments. There were so many comments that CMS went silent for a long time. It took them a year to process all the comments, and then they came up with a new name and did change the proposed RCS1 significantly, but it is still a patient characteristic driven model. So the PDPM is proposed, and it is going to be effective October 1 of 2019. So fiscal year 2020. But they still are accepting comments, and AMDA has been working with ACA, AHA, a lot of the professional organizations in post-acute long-term care, ASCAP, the therapy associations, NASL. And we've been having calls, and we've provided valuable feedback, and ACA is drafting a letter to CMS. And AMDA, proud to say, Dr. Crecilius, Walter Len, myself, and Alex have been involved, and we've made several valuable points which are going to be featured on the letter. And actually, I just got an email that they're calling for another call before they draft the final letter to discuss the ICD-10 utilization in how patient characteristics are established. One of the things, just so you know, with the PDPM, there are going to be 5 different buckets under which a patient's care is going to be measured under. One is the nursing section. The second one is non-therapy ancillaries, which would include pharmacy costs, IVs and TPN, for example, and lab, radiology. All of that would be under that section. And then the third section, the main bucket, is therapy. It is broken down into 3: PT, OT, and speech. So there will be point systems based on patients' ICD-10 diagnoses and some functional status assessments in MDS. The residents or patients are going to be assigned point values. And then under each bucket, there will be a payment that's going to be made. And so the total payment the nursing home gets will be based on the summation of all of the points that the resident receives under all 5 buckets. So that's the model for PDPM. One of the things that's baffling us is, the ICD-10 obviously is very complicated, complex. Even physicians have a hard time picking the right code often, and Rich will tell you this, and ACOs are struggling with this because most of our risk stratification is based off of ICD-10 coding. And now we are depending on MDS coders who are, nurses, not as skilled, not as knowledgeable generally as physicians would be in terms of diagnoses. And we're expecting them to code accurately and CMS to decide how much the nursing home is going to get paid based off of that. So what ALCA is proposing is, again, this is just a proposal. CMS hasn't yet considered it, is maybe a checkbox approach. They are going to propose asking simple questions such as, in the preceding hospitalization, did this patient have, for example, a cardiac condition or a lung condition that was actively managed? Or was the patient treated with anticoagulants? So some of these would pick up the general category in which these ICD-10s would fall under. But again, it's oversimplifying the process of reporting patients' characteristics. And I did make a point yesterday on the call that, perhaps if you are automating this process and you're using a grouper, which would then pick these diagnostic categories, we might erroneously upcode the patient's clinical category. Just to give you an example, I mean, if it is cancer, obviously, generally you think cancer chemotherapy, cancer treatments would be a high category of expenses. But if the patient is on hormonal treatment for breast cancer, that wouldn't necessarily drive up the cost a whole lot. So just getting DVD prophylaxis, for example, after routine hospitalization shouldn't trigger the cardiac and the coagulation cascade category. So there were some points like that. I'm sure CMS is going to look at that too. The good thing is this is still in the early stages. CMS is still inviting comments, and we are part of that. We're very much part of that. But I brought it up here because we have quite a few experienced folks here that are used to how SNFs work and how they get paid. And if you have any ideas, comments, please feel free to pass them on to us. ACA is obviously very receptive, and they appreciate us joining with them in providing comments to CMS. Any questions about that? Any concerns, questions, anything I can answer?
Rajiv, this is Alex. Just so everybody is clear on where this is coming from, this was included in the Skilled Nursing Facility Prospective Payment System rule, proposed rule, which is an annual rule that comes out to update the payments for SNFs. So this was included in that rule, and comments are due, I believe, June 26th. So as you mentioned, the comment period is still open.
Right. And just to simplify this, I know I went through quite a few of detail here, but how they're proposing to capture this patient characteristic is through the ICD-10 that would be reported on MDS, on I-8000. So that's a box where you put in your ICD-10 category. There's concern also as to which diagnosis goes in there, because a lot of times what the resident got in the hospital may not be the same category, same diagnosis that we are treating in the nursing home. It may not be the one that reflects their care complexity the best. So there are quite a few questions and unanswered questions still, but that's the way CMS is expecting that SNFs will be paid going forward, at least as of October of next year. And I know the reason why we are talking about it, obviously, is as medical director and attending physicians and APNs, we would have the most knowledge of patients' characteristics, and we should be actively engaged and involved with SNFs in helping them get fair payment for their services they provide. And that's one of the reasons why we are involved in it. And the second reason is at some point, we are going to be affected by the costs incurred by CMS as well, because as you know, as part of MIPS, cost is going to be a factor that's going to be increasingly important. Right? Any comments? Any questions? Okay, Alex, you're up next.
Okay, quiet group. So the only thing I just wanted people to have a sense of what's happening in the future is that, so typical annual rulemaking cycle, the physician fee schedule typically comes out well, by law, it has to come out by July 4th. So it has been delayed in the past, but we don't anticipate so. It's already at Office of Management and Budget, which clears these rules. So in that physician fee schedule typically is the updates to, as the title states, updates the payment to physicians, and there will be changes to the quality payment program, which means MIPS and APMs. So we've been working with the coalition of folks around some changes to MIPS, particularly around simplifying it and making the categories of MIPS not be so distinct and sort of sit out on their own, and getting cross credit, for example, for reporting and quality, getting some credit in other categories. So there's some conversation around simplification that's been a dialogue with CMS and some other things. But I wanted everybody know that rule will come out before our next call, and we certainly welcome your input when that comes out. Typically, the comments for that rule are due somewhere around Labor Day. So that we will be engaged with the practice group network and the practice management section as a whole in our policy committee, but it's a sort of an all hands on deck effort to try and come up with some comments. But I want to stress that these rules are really the opportunity to make your feelings known about how the quality payment program works. It's great to talk about it at conversations like this or at the annual meeting and complain about it, but the only way CMS is going to hear you is if we put it in comments in our letters. So please pay attention to that rule. We'll have summaries, we'll have calls about it, but I just wanted you to be aware of it coming out soon. That's all I had. Any questions or anything else regarding anything we've talked about? Okay.
Thank you, Alex. So the next section is new business, and this is also the open discussion. We'd love to hear new ideas, what you like about PGN, what could we be doing better, and how could we grow our membership. Obviously, strength is in numbers, both for our AMDA membership as well as for PGN. I'd like to hear your thoughts on that. And we also want to hear about topics for our next annual conference. As you know, the session is open. We can propose talks for next year's conference. So if you have any ideas, any requests, anything that you're willing to do, we'd love to help put up talks and put up sessions. So please speak up. And the sessions the topics could also be the business side of medicine. So it doesn't have to be clinical, can be administrative. It appeals to the entire practice group network. So we have the latitude to add topics that might be appealing to your practice managers, administrators, not necessarily clinicians.
Well, and if anybody has any ideas that, come up within the next few days, feel free to send us an email and we can certainly see if we can incorporate them in some way.
Okay. Any other topics? Anything you want to talk about? It's open floor. All right. thank you for participating. We'll save 10 minutes for everybody on your schedules. But we will have this as a quarterly call. Lori will send out invites. And again, as she said, please feel free to email anything that you can think of, either to improve our membership, PGN or AMDA, as well as the topics that you might want to see at the next annual conference, or anything else that comes to mind. And the topics that Alex talked about or I talked about, even if you think of something later on, please feel free to email Lori or myself or Alex, and we're happy to hear from you. Thank you. Have a great day.